All right, Michael brought up something which can be on the registry related to allergic reactions. Blood transfusions. We don't typically do blood transfusions in back of the ambulance. However, there's a lot of rural EMS systems that will pick a patient up at the ER and they will transport blood, all right, that's hanging on the patient. They can't start it, but they can transport it. Remember, this is not a Dallas Metroplex registry test. It is all things EMS, regardless of the type of system. If you have an allergic reaction to a blood transfusion, turn the blood off, flush or change out the IV set to where we're getting the products out and not continuing to put them inside the body, and then you would treat them for anaphylaxis. But most importantly, you have to stop the products from continuing to go in and either change out the IV setting or flush it completely and get all the products in the blood out. A lot of times it's either the wrong type of blood or there's some sort of protein inside that blood that the person actually starts to react to. That's why a lot of times they'll try to use O negative. Universal. That way they don't have a positive A or B antigen or an RH factor. But sometimes it's a protein in there that the person's actually allergic to. So if it says you're transporting a patient, you're doing a critical care transfer, patient has blood hanging, they start to become short of breath and have a rash, turn it off, discontinue it, change the IV set, or flush it. They're not going to list both. They'll put one or the other, and then treat them for anaphylaxis. All right, but most importantly, we got to keep that blood from continuing to go in. All right. Any questions on that?
Yeah, I mean, so by changing out the IV set, does it mean take everything out completely? And just
Basically, disconnect it at the hub, pinch it, and then plug a whole new bag and set into it.
Okay. So
You don't got to pull the catheter out. We're just basically disconnecting that and then putting the new set and then bag of saving on it. Sure. And then rub fluids wide open and trying to loop it's already gone in. All right. Psychogenic shock, panic attacks. You probably ran a few of these. Some of y'all more than your fair share. Let's kind of look at what's going on in a panic attack. Normally, we have a pulse ox of 96 to 100% and an end-tidal CO2 of 35 to 45. In order to maintain that, we're typically breathing at 12 to 20 breaths per minute. Now, in a panic attack, they typically, for an emotional stress reason, they will typically double their ventilations. So if I go from breathing 20 times a minute to 40 times a minute, I am inhaling twice as much oxygen as normal, correct?
Yeah, right.
So as a result of that, my O2 level will actually go up. Your pulse ox is going to stop at what number? 100. If we were to actually look at the blood gases, 7.35 to 7.45. This way is an acid. This way is a base. PaO2 is 80 to 100. Pulse ox is 96 to 100. PaCO2 is 35 to 45. End-tidal CO2 is 35 to 45. And your bicarb is 22 to 26 milliequivalents. Here's what that means. PaO2 is if we were to pull an arterial blood gas. All right? Obviously, we can't do that in the field. We can measure pulse ox though. PaCO2 is if we were to pull their blood and see how much carbon dioxide's in it. We can't do that in the field. But we can measure end-tidal carbon dioxide. This pulse ox is going to stop at 100, but the PaO2 may actually go 2 to 500. And basically what that means is on the hemoglobin, which is what oxygen and carbon dioxide ride on, the red blood cell. One side carries oxygen and one side carries carbon dioxide. That's why it's called carboxyhemoglobin. What's the name of your red blood cell?
Hemoglobin.
A erythrocyte. What's a white blood cell? Leukocyte. All right? So erythrocyte is your red blood cell. That's where your hemoglobin's found. The hemoglobin transports oxygen to the cells, the trash and carbon dioxide back out. Now, a pulse ox is going to send the light through this red blood cell, and it's going to see how much of the light is bounced back. That's how it gets the oxygen percentage. The pulse ox stops at 100%, but you could actually have multiple oxygen on that one hemoglobin. It's like you and a hot chick sharing an inner tube going down the river. There's two of you on that one inner tube. So that would make this 200, 300, 400, 500, but the pulse ox stops at 100. Does that kind of make sense? And if you stop and think about it, if I'm inhaling twice as much as normal, I'm going to inhale twice as much oxygen as normal, which is going to raise that oxygen level in the blood. It's just the pulse ox isn't that fancy to measure it. All right? I'm exhaling twice as much CO2 as normal. So as a result of that, my CO2 level will actually go down. So when I have a panic attack and I'm breathing at 20 to 40 times a minute, oxygen level goes up, carbon dioxide level goes down. If oxygen level goes down, carbon dioxide level goes up. They have the opposite effect on each other. Remember, carbon dioxide is exhaust. It's trash. The hotter the fire burns and the more free burning it is, the less products of carbon and the less smoke there is. Think of a natural gas flame. That thing's so hot and burns so clean, there's hardly any smoke from it. Compared to trying to burn a tire where it can't completely burn the tire at once, it puts all this thick carbon exhaust off. So the more oxygen, the less exhaust there is. So when this person starts hyperventilating and they get high levels of oxygen, their carbon dioxide level goes down. So this person is what we call hyperoxemia, high oxygen, and hypocarbia. Hypo meaning low, carbia meaning low carbon dioxide. Well, where does carbon dioxide come from? It does not come from the lungs. That is not where carbon dioxide comes from. That's where it's moved from the blood across the alveoli into air, but that's not where carbon dioxide is created. Carbon dioxide is created at the capillaries. Because what happens at your cells is you move oxygen and sugar into them. They burn them for fuel to create energy, and that produces acid, which breaks down to water and carbon dioxide. Because remember, acid is H2CO3. So the more oxygen and sugar that goes to the cell, the less acid that's produced. The less acid that's produced, the less carbon dioxide is created. The more acid that's produced, the higher levels of CO2. So stop and think about this. Somebody in metabolic acidosis, they have a large level of acid. So if I increase the acid, I'm going to increase the amount of CO2. How do you get rid of CO2?
Breathe it out.
You breathe it off. So stop and think about Kussmaul's. Kussmaul's is designed to have a normal inhalation, but they have a prolonged exhalation to blow off the acid. Does that kind of make sense? CO2 is created at the cells as a byproduct of acid. It is taken from the blood and turned into a gas in the alveoli to where we can exhale it. But it's created at the cellular level. Respiration occurs at the cells Ventilation is the process of moving air in, putting it into the blood, and taking the trash and byproducts from the blood and moving it out of the body. That is respiration or ventilation. Cellular respiration is here. So if they're blowing off all their CO2 and they have high levels of oxygen, they're not creating as much acid anymore. So as a result of their CO2 and acid going down, they become alkalotic. They became alkalotic because they had more oxygen to the cells than they needed, which created less carbon dioxide. This is a cellular respiration issue. So how do we label this person? Respiratory alkalosis. If we look at a panic attack, what signs and symptoms does a panic attack get? Besides they say they can't breathe.
Syncope.
Okay, blue lips, carpal pedal spasms, chest pain, tingling. So let's stop and think about this. If I vasoconstrict and I steal the blood from your lips, I can no longer take a deep breath. I can no longer suck in a high amount of oxygen. That's why their mouth gets numb and tingling. If I make your chest hurt, I can't take a deep breath. I can no longer suck a good amount of oxygen in and eliminate a good amount of CO2. If I vasoconstrict your fingers and toes, I'm decreasing the amount of oxygen going to your fingers and toes through vasoconstriction. So the fingers and toes will go from aerobic metabolism to anaerobic. And if I decrease oxygen going to the cells, I increase acid. And if I increase acid through vasoconstriction, I increase carbon dioxide. That's why a panic attack gets carpal pedal spasms, because they are trying to create more acid and more carbon dioxide at the cellular level by shutting off blood flow. Essentially, they're trying to make their cells hypoxic through vasoconstriction. When they make their cells hypoxic, they produce more acid, which produces more CO2. When they get enough acid that they're no longer alkalotic and they move back towards a normal pH, what happens to carpal pedal spasms?
Quit.
They relax. And then they start hyperventilating. And when they start blowing off the acid and they become alkalotic, they'll constrict again. So we have to understand the way this works. So, too much acid equals too much CO2. How do I get rid of CO2? I blow it off.
So when someone's going on a like a panic attack and they're breathing a lot, they're bringing a lot of air, but they're not getting rid. Are they getting rid of the CO2 or they're not?
They're eliminating all their CO2.
Okay.
So they empty all their CO2 out, so we got to rebuild it.
Okay.
Where do we rebuild it at?
Cellular level.
At the cells by shutting off blood flow and oxygen to them. We can also have them hold their breath. If they hold their breath, they can't take in oxygen and they can't blow out CO2. So if I make them hold their breath, I'm lowering their oxygen and bringing their CO2 up. In the old days, they used to make them breathe into a what? Paper bag. Because if you keep rebreathing air, you're not getting oxygen, and you're getting that carbon dioxide back in your system to affect that level and bring your CO2 up. The problem with that is if they were having hyperventilation because they were acidotic, or hyperventilation because of a head injury, or hyperventilation because of an overdose, we would make the problem worse. So they said, no more paper bags because you dumbasses don't know what you're doing. And they were right. So let's stop and think about things other than a panic attack that can make you hyperventilate. Hyperventilation can be the result of metabolic acidosis. So what type of patients can be metabolic acidosis?
Like
What type of diabetics? Or
Type 1.
it could be basically any diabetic that their sugar's what? High. Hyperglycemia, DKA. Diabetic ketoacidosis. They get diabetic ketoacidosis How do we get rid of acid? Breathe it off, pee it off, sweat it off, so they get Kussmaul's to blow off the acid. Who else can have metabolic acidosis? Renal failure, dialysis patients. The whole job of dialysis is to take the trash and pee it off. That trash is acid and waste. If I can't pee off acid and waste, the only way to eliminate the acid and waste now is to breathe it off. So you can see Kussmaul's as part of metabolic acidosis to blow off the trash. Dialysis patients. Who else?
People with eating disorders.
Okay, they will probably not be metabolic acidosis. They would probably be metabolic alkalosis because they're throwing up all their stomach acid constantly. What type of overdose?
Opiate.
An opiate does not affect your stomach acid. Acetylsilic acid. Tricyclics. Cocaine will not actually cause metabolic acidosis. It's more alkalosis. But think of this, aspirin. Aspirin's acetylsilic acid. I'm essentially taking a handful of acid and overdosing. What's that going to do to the acid level in your stomach? Increase it. That would make you stomach problem, more acid, metabolic acidosis. What about a Tylenol or acetaminophen overdose? What does it destroy? Liver. And what's your liver's job? To clean and detoxify the blood. Well, if I destroy your liver, you can't take out the trash, so the trash is going to build up. So a Tylenol overdose will cause metabolic acidosis and cause Kussmaul's. Does that kind of make sense? What about a urinary tract infection where they can no longer pee? If they can't pee, they can't eliminate waste. That would cause metabolic acidosis. Metabolic alkalosis would be because I am getting rid of all my stomach acid. I am burning through all my nutrients. Or, here's the most common metabolic alkalosis we will see in the field, besides nausea, vomiting, diarrhea, where they've thrown up all their stomach acid. You run on a 72-year-old female, she's weak. She reports having a little bit of shoulder pain and left arm pain. She's a diabetic, and she has had acid reflux for the last 3 days to the point she's taken a whole bottle of Nexium, Prilosec, whatever. Those are all antacids. If I overdose on antacids, what's it do to my stomach?
Makes it alkalotic.
Makes it alkalotic. So she has taken so much antacid, she's now metabolic alkalosis. What's actually wrong with her? What was she having? Any idea? Heart attack. Why? How do we know that? Female diabetics do not typically have chest pain because of neuropathy from the sugar eating away at their nerves. So typically, they will have what feels like acid reflux or some just vague pain or uncomfortable feeling in the upper epigastric region. They'll still have some shoulder pain or neck pain because of the referred pain from the heart, but the heart has so much neuropathy or necrosis that they don't typically have chest pain. So she's like, oh, I'm belching a lot. Man, I feel kind of tight and full through here. And she starts popping antacids to the point she's overtaken them. That's where she got metabolic alkalosis. She thought she was having an MI or acid reflux. In reality, she's probably having an MI. You have a female diabetic weak with arm pain, jaw pain, neck pain, run a 12 lead. Run a 12 lead because they're most likely having what's called a silent or atypical MI. They won't typically have chest pain with it. Female diabetic, acid reflux, do a 12 lead. Weak, arm pain, jaw pain, do a 12 lead. A lot of times they'll self-diagnose and overdose on antacids. Prilosec, omeprazole, Nexium, Tums, Rolaids. Those are all antacids, and if they take too much, you'll make a metabolic alkalosis. You have a 26-year-old female breathing 6 times a minute with pinpoint pupils. If she metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis.
Respiratory acid.
If she's breathing 6 times a minute in pinpoint pupils, she's what type of overdose?
Acidosis.
Opiate. Which means she's only breathing in 6 times, which means she's not getting enough what? If oxygen level goes down, acid goes up. That's a respiratory issue because she's not breathing enough, so she's respiratory.
Acidosis.
So would a benzo like Xanax. So would a tricyclic. Anything that makes them breathe slow will cause respiratory acidosis. Anything that makes them breathe fast, they're blowing off their acid. See the difference? What if I had this? I'll give you a scenario. 52-year-old male in IDDM, ate large breakfast, and has extreme thirst. You should suspect metabolic alkalosis, metabolic acidosis, respiratory acidosis, or respiratory alkalosis.
So he's been peeing.
First of all, what do you think's wrong with him? DKA, diabetic ketoacidosis. Did they give you 2 out of 3 signs and symptoms of DKA? First of all, non-insulin dependent diabetes mellitus. That's what NIDDM stands for. Ate a large breakfast and extreme thirst. Polyphagia, extreme hunger in diabetics, especially high blood sugar. Polydipsia, extreme thirst. Polyuria, extreme urination. They gave you 2 out of 3 signs and symptoms of DKA. So he is DKA, which would make him metabolic acidosis. You are going to see 3 to 10 pH questions on the registry and on the final. A couple of them will be scenario questions like what we worked through. Might be an opiate, might be a Tylenol overdose, might be a aspirin overdose, might be a DKA, or I may just give you a blood gas. I may give you this, 7.33 PaO2 100, PCO2 60 or 70, bicarb 18. Start here. Acidotic or alkalotic or just right?
Acidosis.
Oxygen good?
Yeah.
So it's not respiratory then.
No.
CO2 out of whack?
Low.
Yes.
Is bicarb out of whack? If bicarb's out of whack, it's metabolic. So I have metabolic acidosis, so why is my CO2 high? Because the more acid there is, it breaks down to carbon dioxide, which is going to make that level climb.
We see questions like that on the national registry, where this is the patient's.
Yep. They will list the blood gas, and out of this, they will say metabolic alkalosis, metabolic acidosis, respiratory alkalosis, or respiratory acidosis. You're going to see 1 to 3 that are just numbers, and then you're going to see 3 to 6 that are scenario based. Like what we went over, the opiates, the aspirin, the Tylenol, the nausea, vomiting, diarrhea, the missed dialysis.
So that would have been metabolic acidosis?
Yep. What if I gave you this? Acidotic or alkalotic?
Acidotic.
Is bicarb normal?
Yep.
So it's not metabolic then. So I have respiratory
Acidosis.
acidosis. Hypoxia equals high CO2. What if I gave you this? Alkalotic or acidotic? Bicarb normal or out of whack?
Out of whack.
So it's metabolic. As soon as that bicarb's out of whack, it's metabolic.
Metabolic acidosis. Alcohol.
Metabolic alkalosis. Is oxygen good?
Yeah.
CO2 good?
Yeah.
CO2.
What should you put on your dry erase board?
22 to 26 with bicarb. If it's out of that, then it's.
I would probably write this. But yeah, if the bicarb's out of whack, it's metabolic.
What's the range of bicarb?
22 to 26 milliequivalents. What if I gave you this? Nope. 7.35. Okay, 7.35.
They're good.
So I'm right at the end to where I'm almost touching acid, correct?
Right.
Oxygen good.
Uh-huh.
Metabolic.
CO2's out of whack.
Yeah.
My bicarb is barely out of whack. So here's what this person is. They are acidotic, but right now between bicarb and blowing the acid off, they're able to keep from going full-blown metabolic acidosis. This person's moving towards metabolic acidosis. They're just not there yet. So they're basically compensating by hyperventilating, doing what? That's why the CO2 level's high. The bicarb, it's dumped its bicarb, and now it's burning through it. That's why it's a little bit low. So this person's actually borderline metabolic acidosis. And when we stop and think about it, okay, you're going to try and fight moving towards that acidotic state through using your respirations and dumping your bicarb. Does that kind of make sense? They're borderline. They're not there yet, but they're borderline. All right, they're moving towards it. What if I gave you this? What do you think's wrong with this female?
Respiratory alkalosis.
She's most likely having a what? Panic attack. She's respiratory alkalosis.
Panic.
All right, dry erase board. Dry erase board.
Can we go over a class for that, right?
Yeah, we will. We'll add to it throughout the day and tomorrow. Dry erase board. I will also give you blank paper for your final, to where you can practice writing your dry erase board. The time we're done today, you should start practicing your dry erase board tonight. That's what you learn on it. And here's why. You're going to have a minimum of 80 questions on the registry. 20 to 25 of them are pilot questions. That takes you down to roughly 60 questions. You only have to get about 45 of those 60 correct. If we can have 10 of those that we can look at our dry erase board and answer, now you're talking about only having to get 30 to 35 correct on your own.
So you're saying there's a chance?
I'm saying there's a chance if you do your part.
You said on the bicarb, if that's out of whack, it's automatically metabolic?
Correct.
Okay.
Correct. So, for sure, I would put pH on there. And I'll go over everything you should have on your dry erase board before we're done.
So bicarb, even if it's high, like it's still metabolic.
Don't worry about it. Don't get so technical, just go. If it's not 22 to 26, it's metabolic, and look at your pH. Move on. Don't sit there and go, well, is it early? Is it late? Have I dumped it? Have I not? Don't do that to yourself. It's either 22 to 26 or it ain't, and I'm picking metabolic. And then I'm looking at, is it between 3.5 and 4.5, or is it out of whack?
So I feel like I have a pretty good grasp on the acidosis part. What are some things that are alkalonic besides the panic attack and the Tums overdose?
Nausea, vomiting, diarrhea, excessive dehydration. They go to dialysis and they take too much fluid off them. It's really about it.
So that's just anything that would.
The respiratory alkalosis by itself is a panic attack. Now, you can have metabolic acidosis with respiratory alkalosis, aka respiratory compromise. And what that means is I have metabolic acidosis and I'm hyperventilating so much I bring my CO2 down. That's metabolic acidosis with respiratory compromise because I'm trying to blow it off. But respiratory alkalosis outside of hyperventilating, not really one. Unless you flooded them with oxygen. So stop and think about this. I have a stroke, a head injury, or a heart attack. And I put them on a non-rebreather, and they had a pulse ox of 100% before I put them on a non-rebreather. If I make their oxygen level too high, they're going to vaso what? So if you put a non-rebreather on a heart attack, stroke, or head injury, and they don't need it, you would actually create respiratory alkalosis because you're making that oxygen level way too high, and you'll cause them to vasoconstrict. That's why we say consider oxygen, but you don't necessarily have to use it in a heart attack or stroke, because too much oxygen will make them respiratory alkalosis and make them vasoconstrict. I don't want a heart attack to vasoconstrict. I want a heart attack to vasodilate, which is why I give them nitro. I don't want a head injury to continue to vasoconstrict or a stroke, because that's why they have intracranial pressure, and high flow oxygen can make them vasoconstrict more and make them bleed more. So high flow oxygen could create respiratory alkalosis. All right. Any other questions on the acid-base balance? So the best treatment for a panic attack, calm them down. If they won't calm down and slow down, sedate them down. All right, sedate them. Probably never to maybe once or twice in your career will you actually have to sedate a panic attack. All right. I would just say this, that if it's one of those things that you're like, oh my God, that's horrible, probably gonna have to sedate it. The one that comes to mind was that I've actually sedated, and like you guys, depending on the socioeconomic area of the city you work, you will see more panic attacks than some of the other areas. I always joke that North Irving has a lot of wine and Prozac, so they don't have panic attacks. Down south, it's just part of certain cultures. It is what it is. You know, it's just part of that socioeconomic area. We're paid the same. We ran a lady that she was in the country illegally. She was working at the El Pollo. She had been sending money back to the cartel, and once she paid enough money down, they smuggled her in. At least this is her story. They smuggled her in, and once she paid enough money, they were going to bring her 11-year-old daughter up for her. You know the cartel as well as I do, but that's what they told her. So her dad had been extremely sick. She had to take a week off of the fast food restaurant, and she hadn't sent him any money. So as they're getting ready to close, they call her on her cell phone, and this is her story. I believed her by how upset she was. And she wasn't actually telling me the story, her coworker was. She said that they put her 11-year-old daughter on the phone. They let her talk to her for about 30 seconds. They told her, you haven't sent any money in a week. We told you the issue. And they shot her in the head and hung up the phone.
Jesus.
And I was like, holy shit. We ended up giving her some value. We didn't carry Versed yet. We gave her that. There was no way we were calming that poor lady down. I don't know if they really killed her daughter or not. Truth be known, she will never know. There's a chance that she is probably in the sex trafficking trade now. But that poor lady may never know what happened to her daughter. We ended up sedating her. There was no way we were going to calm her down. So that's one that comes to mind that we've actually sedated. 99.99% of my career, it's like, so you're breathing down. Tell me your complete address. Tell me your complete, and why would I tell them that? So they can talk and quit sucking air in, get them to start talking in full sentences to slow them down, and you can coach it. 99% of the time, coach the breathing, calm them down. It's that rare occasion where you're like, holy shit, that's horrible, that you may have to consider sedating them. Registry will want you to pick a benzodiazepine for sedation. for seizures as well. So a lot of times they'll give you Valium for seizures, Versed or Halidol for sedation. Versed for sedation, like that lady with the panic attack. Versed for sedation prior to like pacing or cardioversion. Halidol for paranoid schizophrenia, for psych issues. All right. I will tell you that last week on one of our registry exams that we ran here, they had a pediatric seizure, and the ambulance they were assigned to per test did not carry Valium or Versed. It carried Ativan, and they could not get an IV. Well, Ativan can only be given IV or IM. So they were wanting the medics to work through the problem and figure out, okay, I have to give Ativan. They gave the I forget the age of the kid, a couple of years old. They gave this weight, and they wanted 0.2 mg per kilogram, and he weighed 7 kilograms. So what they were wanting the medics to do is go, well, normally I'd give Valium and Versed. Oh crap, it's not there. Here's a protocol that says Ativan, figure it out. And that was on the out-of-hospital scenario that the kids had last week. And a lot of them, they just vapor locked. Ativan is like Valium and Versed, except it can't be given rectally. Valium can. It can't be given intranasally. Versed can. Valium can't be given intranasally because it's oil-based. Versed can't be given rectally because it's water-based, and we can give it intranasally, so there's no reason why. By the way Ativan is diluted, it either goes IV or IM. It doesn't go rectally or intranasally. So they were wanting the kids to work through that problem. But they gave them a protocol, and it had Valium and Versed crossed out and said, here's your drug. All right? It's just a matter of working through the problem. So, Valium for seizures, Versed for sedation, Halidol for paranoid schizophrenia. On a rare occasion, they may throw an Ativan or lorazepam at you. It can be used for seizures or sedation, just like Valium and Versed can. If they just say give a benzo, that means you picked one of those three and gave it. Sometimes the registry won't use a drug name at all. They'll use a class. All right? They'll use a class of drug, which would be a benzo. Benzos are used for sedation and seizures. All right? So you may have to sedate that panic attack. While we're talking about panic attacks and acid-base balance, you're going to see 3 to 10 capnography questions. All right, so let's make this 0, 10, 20, 30, 40, 50. What if I saw this type of waveform? And remember, they're going to show you a 6-second capnography. If they show you capnography, it's going to be a 6-second, just like a strip. So this right here is in the teens, and I have 2, 4, 5. That's a 6-second capnography strip. The CO2 level never gets above 20. How many times a minute are they breathing? 30, so they're hyperventilating. So you need to tell them to what? Slow down. If you had this person intubated, what would you need to do with your BVM? Slow down, because you're hyperventilating. What if you saw this?
They're not breathing.
Hypoventilation.
Speed it up.
You need to speed it up. What if you saw they're breathing about 24 to 30 times a minute, and it's in the mid-40s?
Kuzma.
Huh?
Kuzma.
Why'd you pick that?
They're trying to breathe off the acid.
They're trying to breathe off the acid. They're hyperventilating. If it wasn't because of a metabolic acidosis and they were hyperventilating, what would CO2 do? Drop. If they're hyperventilating and the CO2 is normal to high, they're trying to blow off all that acid from that DKA, that renal failure, whatever. Right? So if I have hyperventilation and the CO2 is normal to high, that's Kussmaul's. They're trying to blow off all the acid. What if I gave you You're working a CPR. You're working a CPR and you have that. ROSC. Here's what's happening. They're doing CPR. They're moving blood, but not moving it very well. So we're getting a little bit of trash, a little bit of CO2 back. All of a sudden, the heart starts to beat, supplement our compressions, and it's able to force all the trash out of the capillaries back into the bloodstream all at once, and I get that sudden spike. That's an indication I got ROSC. Does that kind of make sense? What if I see this? And I'm doing CPR. I need to change people doing compressions. They're not doing deep enough. They were doing a good job, and now they're getting tired and they've lost hand placement. If that CO2 starts to fall, I've lost hand placement. If it was to do this, I lost my what? I lost my tube or my capno. But chances are I've lost my tube. If it's a dotted line, that's a disconnector capno issue. If it goes flat, that's usually the tube's dislodged or I've completely disconnected it. What if I saw this? You have a person, you're transporting them from a care now to the ER and they're intubated, and during your trip, you start to see this. Yeah, they're starting to breathe on their own. The paralytics are wearing off, so what should you do? Give them more. And you give them some more Versed. Put their ass back down. All right, that's called the Curad clep. All right, they're starting to wake up and breathe around the anesthesia. All right, so those are some of the things we may see along with the capnography. And of course, everybody in here should know capnography that does this is bronchoconstriction or bronchospasm. They're wheezing. All right, any questions on that? Let's look at septic shock.
Were you looking at the rate for when you were doing the faucets? Is that what you were wanting us to look at, or what? Like, along with the...
I want to look at both. I want to look at the amount of CO2 and how quick.
Okay.
Left to right is rate, up and down is the amount of CO2.
Okay.
Sepsis. If I look at sepsis, there are two types of sepsis. There's early and late. When a person first gets an infection, they're going to have an immune response. The immune response is going to cause them to dump glucagon because that's part of the sympathetic nervous system. Well, in your pancreas, your alpha cells release glucagon, your beta cells release insulin. So anytime I have a fight or flight response, your epi release and your immune system is going to trigger the pancreas to release alpha cells and beta cells. Here's what happens. The alpha cells go to the liver and they release stored glycogen. This stored glycogen enters the bloodstream and it gets converted to glucose. Well, in order to move that increased glucose into the cells, I have to release more insulin. So you see how the fight or flight in the immune system triggers the pancreas to change my sugar levels. So when you first get an infection, or you first have that fight or flight in that immune system response, because I'm dumping all the sugar from the liver, I'm going to increase my blood sugar. Blood sugar on the registry will be called VGL, which is blood glucose level. It may also be called a D-stick. It may also be called FSBS, which is finger stick blood sugar, or it just may be called BS.
Bullshit.
Depends on where you work. What do y'all call it in Dallas?
Sugars.
D-stick.
D-stick, sugars, check the sugar blood.
The sugars.
All right, the sugars. Some places call it a chem strip. Piper still calls it a chem strip, which tells me he went to paramed school about the time I did, maybe a little bit later than I did. You know what a chem strip is? No idea? Anybody ever seen how they test pool chemicals? They dip it in the water and then they compare it to the tube?
Yeah.
We used to take blood, put it on a stick, and then we'd rotate the can until we matched the color. It's called a chem strip. That's what we used to check a sugar with before we had the glucometers and stuff. So all those terms are interchangeable. Because the immune system, the liver's going to release stored sugar from the liver, and that's going to make the blood sugar spike. Because the white blood cell in the immune system, I'm going to increase metabolism to fight this infection, therefore they need increased sugar. That increased metabolism is going to increase temp. An infection is good or bad? Bad. What do bad things cause the blood vessels to do? To flush it to the liver and kidneys. So the combination of increased temp and vasodilation will basically speed up your cap refill. At the same time, it's going to drop your blood pressure. So I may have a blood pressure of 70/40, but my cap refill be instant because I've vasodilated and that's where all the blood's at in the fingers and toes. The temp is up from a combination of the white blood cells responding to the infection, the vasodilation, and the increased sugar. This occurs in early sepsis when they're first fighting the infection. This person right here will probably respond relatively good to IV antibiotics. We can't do anything for sepsis other than recognize it, give them some fluids, and take them to the hospital, and the sooner they get IV antibiotics, the higher chance of them pulling through this. This is what we call early sepsis. Even though the blood pressure is down, it's early because the immune system is still fighting, they still got sugar, and they got a temp. That's early sepsis. Late sepsis is the opposite. Blood sugar goes down, temp goes down, blood pressure returns to normal, and heart rate is a little elevated. And this is what I was talking about earlier. If I told you temperature of 102, recent urinary tract infection, not feeling well, almost everybody in here would hammer that that's sepsis. But if I said she's felt weak and ill for 2 weeks, blood sugar is 62, temp's 96.8, blood pressure is 102/60, and heart rate's 112, that is late sepsis. Her immune system is no longer trying to fight the infection. She's dumped all her sugar to try and fight the infection. She has no more fight left in her. It's going to be more difficult for the IV antibiotics to work because her immune system is worn out. Does that kind of make sense? That's why that's late. Medics do a really good job recognizing this one. They do a horrible job recognizing late sepsis.
What do you see first? A decrease in temperature, blood sugar?
It depends on when we get there, but usually you're going to see a drop in the temp first and then the blood sugar. Sorry, didn't know that was there. All right. Yes.
So something I've seen in some lectures about this topic, especially in older patients, or most likely to be septic.
Correct.
A big red flag is basically a normal blood pressure.
Correct.
Right? Because like an old person with a blood pressure of 120/80, unless they're fucking Jack LaLanne,
Correct.
It should be higher than that.
Right. So let's stop and think about this. If I'm 120/80, 80 would probably be considered low for me. If she's 160/100 every day of her life, 102 is really freaking low. But we are so focused on above 90 that we don't recognize 102 is actually really low for her.
For the type of shock, is it vasogenic or distributed?
Either one.
Same thing?
They're the same thing. It's just somebody had to make money on another textbook, so they created another word.
Okay.
If I was to write a textbook, there'd be no words with more than 4 letters. And they'd probably be all beeped out, but a lot of pictures. Nice picture.
So like with the spinal shock or
Uh-huh.
you would also have similar.
In spinal shock, though, I wouldn't have a increase in heart rate and an increase in sugar and an increase in respiratory because the body can't send the messages to tell it to do that. In sepsis, when the blood pressure goes down, my heart rate will go up, my respiratory rate will go up, my temp will go up. But in spinal shock, heart rate and respirations won't go up.
Okay. Does your respiratory rate stay the same in early and late?
Actually, they both should go up. And they're probably going to be in the 20s. They're not going to be in the 30s or 40s, but they'll probably be in the 20s.
Yeah.
All right. Treatment, though, for them is the exact what?
Same.
Same. Treatment's the same, yes.
How does CAPNO play in? Because I know like on our protocols it says to look for below 30, like patients older than 50 and stuff.
So if they're below 30, what are they doing?
Blowing it off.
Blowing it off. So if I have a CAPNO below 30 and they're septic, what's happening is they're becoming metabolic acidosis because of the infection and they're trying to blow it off. Is it going to change anything we do? No. The most important thing we can do for sepsis is recognize it and let the hospital know as soon as possible to where they can activate the code sepsis. If you guys noticed when a code sepsis was called, or if you called one yourself, the nurses are at the bedside and they have everything ready versus if you call and go, hey, I got a 72-year-old female weak, not feeling well. Now you're spending 20 minutes waiting on a nurse to take a report. But if you recognize it's sepsis and you activate it, they're on a total different set of benchmarks and staffing level. And that's why it's important for us to recognize they are septic and call it, because that's the difference between them getting IV antibiotics in the first 20 minutes versus sitting there for an hour in a hall bed. That's why we've created the code sepsis. And what's the most common type of shock? Septic. What do most people in the hospital die from? Septic. What's the nastiest place on earth?
The hospital.
Hospitals. Who's the lowest paid employee at the hospital? The cleaner people. And how they clean? Come over here, they wipe the toilet, then they take the same rag, wipe the door handle. Let's be honest, you guys cleaned some of the beds while you were on your clinicals. That's my point. Y'all do a perfect job cleaning that ambulance stretcher every time when you're done, don't you? I don't either. I'm just saying that. So, and we wonder why we have such a high risk of infection in hospitals. So, sepsis, early versus late. All right. Treatment's the same. We good on that? All right. Cardiogenic shock, we're going to skip. We'll come back to it when we do cardiac. Hypovolemic. If hypovolemic and hemorrhagic are both listed, if it's trauma, pick which one. Hemorrhagic. If it's nausea, vomiting, diarrhea, hypovolemic. If it's trauma and hemorrhagic's not listed, then you can pick what? Hypovolemic. Remember, hypovolemic means fluids of any type. Hemorrhagic is specific to blood. Which one has stage, also called classes? Hemorrhagic. Specific to blood. Make sure you have stage 1, 2, 3, and 4 written down on your notes. Make sure you have 3 to 1 blood volume to saline. It takes 3 liters of isotonic crystalloid, also called saline, to fill the place of 1 liter of blood. 3 liters saline for every 1 liter of blood loss. Make sure that you put that on your dry erase board. We good on phases? Early compensated, reversible, localized, have a pressure above 90. Decompensated, late, generalized, irreversible, have a pressure below 90. Shocks that have warm, dry skin but low blood pressure are what subcategory?
Neurogenic.
Subcategory. Vasogenic or
Distributed.
distributed. I'm vasodilated, so I can't distribute the blood. That's the way I remember it. I'm vasodilated, so I can't distribute the blood. All right. Let's go to page 3. Cardiac.
What'd you say? I'm sorry, vasogenic or what?
Distributed. Yeah. Anytime I have shock with low blood pressure but warm, dry skin, it's this distributive or vasogenic category. And that's where your sepsis, anaphylaxis, spinal DKA, and heat strokes come in. All right. Before we go page 3, let's do a quick review. All right. Represents the atrium firing, and it's upright. The first wave you should see on your EKG. P wave. Represents atrial depolarization. There should be a little bit of pause that allows the atriums to empty into the ventricles. That's called the what? PR interval. There should be 3 to 5 small boxes. Then I have ventricular depolarization, which is your QRS, and then the ventricles reset as part of your T wave. What electrolyte makes the SA node fire?
Put that ass.
Calcium.
Ah, back.
What electrolytes make your QRS fire? Sodium, which starts out extracellular, and potassium, which starts out intracellular. During contraction, sodium moves into the cell and potassium moves out. That's what creates the ventricular contraction. What resets the sodium-potassium pump? MAG. So, if I have AFib or a flutter and the atrium is beating too fast, what electrolyte could potentially be causing that? Calcium. So I need to block it then. So AFib and a flutter gets a calcium channel blocker such as Cardizem or Verapamil. I could also use calcium channel blockers for blood pressure control. How? Well, if I slow the heart rate, I do what to the pressure? Bring it down. You tell your engine driver you got too much pressure on the nozzle, he's going to throttle it down or gate it back. That's what a calcium channel blocker does, such as Cardizem. So calcium channel blockers can be used for AFib and A-flutter when the atrium is beating too fast. It could also be used for SVT, and it can also be used to lower the heart rate, to lower the pressure. All right? The ventricles, if I have VFib or VTAC, that could be a sodium or potassium issue. So I need a drug that's going to work on those electrolytes. What drug works on sodium only? Lidocaine blocks sodium channels only. Well, if it's a calcium or a potassium issue, lidocaine's not going to work as well. So what drug blocks calcium, sodium, and potassium? Amiodarone. Well, as a result of that, amiodarone has a higher risk of bradycardia and hypotension, because if I slow your heart down too much, opposite of tachycardic is bradycardic. If you become bradycardic, what happens to your pressure?
Drops.
It drops. Now, if you're dead, I don't care. Unless you're trauma. If you're trauma and I get you out of VFib or VTAC, I want you to have sinus tach. Why do I want a trauma patient to have sinus tach? To compensate for blood loss and keep their pressure up. Which is why when we look at VFib, if it's medical VFib, they get amiodarone first. If it's traumatic VFib, they get lidocaine first. The first drug in all dead people is what?
Epi.
Epi. If I have an issue where the T wave is starting to become elevated, what does that tall peak T wave represent? Hyperkalemia, high potassium. If the tall peak T wave gets more than 50% the height of the QRS, they are at risk of going into torsades, which is also called polymorphic VTAC. How do I reset the ventricles? MAG. That's why MAG is a drug of choice in torsades. It resets the ventricles. What speeds the ventricles up? What speeds the heart up in general? Calcium. Because it starts the chain reaction of everything else. So stop and think about this. If I have a person whose ventricles are going way too fast and they have high potassium because they missed dialysis, I want to slow it down by giving them what drug?
Calcium chloride.
Slow it down.
Oh, shit. Which one?
So let's look at this. All right. Let's just make sure we have this clear. You have your kidneys. In your kidneys, you have these tubulars at the nephrons. The job of the kidneys is as waste and salt and potassium comes through, their job is to measure water with sodium, and then potassium's always holding hands with sodium. So their job is to measure how much water I have compared to how much salt I have. The more salt they have, the more water they will retain. The less salt they have, the more water they will eliminate. This all takes place in the kidneys at the loop of Henle. That's where Lasix works. So basically it's going, too much salt, keep water to dilute it. Too little salt, piss off. That's what the kidneys are doing. In renal failure, these kidneys can no longer filter water, filter sodium, filter potassium, because they can no longer pee. So as a result of that, they're going to retain water when they go into renal failure. The accumulation of excess fluid and water is going to make their blood pressure go up. They are also, if they retain water, they're going to retain sodium. If they retain sodium, they're going to retain potassium. Well, the higher the level of sodium and potassium, the faster they move, which can end up causing the VTAC, the VFib, or the torsades. With me so far? The higher the level, the more they're going to move. Eventually, they get so fat that they can't move anymore. So as they're becoming elevated, we're at risk for tachycardias, VTAC, VFib, and torsades. Eventually, they get so fat that they can't move in and out of the cell because they're too fat to fit through the door. So if they're too fat to move, what happens to your heart rate? Goes down. They become bradycardic. Or they don't move at all and become asystole. Or they become PEA. Well, if MAG slowed them down, what tells them to move their fat ass through the door? Calcium. That's why renal failure patients that are bradycardic, PEA, or asystole get calcium chloride. Renal failure patients that are in torsades get MAG. Because they have an opposite effect. Calcium's going to push stuff to get moving, and MAG's going to separate them and slow them down. So if I PEA, bradycardia, or asystole in a renal failure patient, I have to make this pump move by giving it calcium to make it move. If it's going too fast, I got to get a referee and give it MAG to slow it down. If I'm right here, and they're not torsades, they're not bradycardic, they're not PEA, they're not asystole, they are just a sinus tach with a tall peak T wave, they are extremely acidotic. How do I get rid of acid? Breathe it off, sweat it off, pee it off. What's messed up on them? Their kidneys. What can they not do? Pee it off. So now I have two ways to treat this person. Definitively, they need dialysis. But I can't do dialysis in the back of my ambulance. So I have to counteract the acid, and I have to make it to where they can blow the acid off better. So guess what two drugs are given for hyperkalemia with tall peak T waves? Bicarb and albuterol. Bicarb will help deactivate the acid and break it down to water and carbon dioxide. Albuterol will make the lungs what? Open up, which allows more surface area to blow off the acid. Albuterol also, because of its beta properties, will cause the sodium and potassium to move. Because here's something we need to understand about sodium and potassium. This not only occurs in the heart, sodium and potassium movement occurs in every nerve and every muscle. So right now, if you relax your arm, sodium is extracellular, potassium is intracellular. If you contract your muscles, sodium moves into the cell and potassium moves outside the cell. That's what happens during muscle contraction. So during bronchoconstriction or contraction, guess where sodium's at? Inside the cell. And potassium's on the outside. Well, what's the job of albuterol? To open it up and relax it by moving this potassium back into the cell and sodium out. So not only am I making my lungs bigger through relaxation, I'm moving that sodium and potassium. That's why albuterol can be given to renal failure patients, DKA patients, and metabolic acidosis patients to help move the acid to where they can breathe it out. Does that kind of make sense? Now, if it's so stuck albuterol won't work, what else could I give to move the acid? Mag.
In the book,
Refractory asthma, they're locked down and it won't respond to albuterol. And it won't respond to epi, so then I give mag to what? Relax it.
in the book, it says for hyperkalemia 2, consider calcium chloride or gluconate.
Correct. Now, so here, remember the equation. Hyperkalemia, as it goes up, they're at risk for tachycardia. Eventually, it gets so high that they're fat, they can't move at all. They can't move at all now, they're bradycardic, PEA, or asystole, the calcium chloride to get the shit moving. So if they're fast, we got to slow it down. If they're hyperkalemic and slow, we got to speed it up by giving the calcium chloride and gluconate. Opposite sides. Mag slows it down, opens it up. Calcium speeds it up.
And is the bicarb just indicated for wide QRS?
It can be. It can also be used for metabolic acidosis,
I've
but
seen that.
albuterol is going to work much better. But yeah, a wide QRS in metabolic acidosis, you can give bicarb. But if it's VFib, VTAC, torsades, bicarb's not really going to do anything for it. We got to treat the rhythm first. All right? Now, let's go a step further before we get into our algorithms. If sodium moving into the cell causes a contraction, what drug blocks sodium? You already told me lidocaine. So if I take a needle or a knife and I cut your skin, what happens is the nerve cells will detect the pain. They'll tell sodium to move into the cell to create an electrical impulse, and that electrical impulse will go through the nerve to the brain and go, damn, that knife is sharp and hurts. By giving lidocaine, it blocks sodium from moving into the cell. Well, if sodium never moves into the cell, there's never an electrical spark created, and there's never an impulse that goes to the nerve that goes to the brain that says that knife is sharp. That's why lidocaine is used as a local anesthetic prior to stitches, prior to dental work, etc. Because if I block sodium, there's never a pain impulse created. So that kind of makes sense on how lidocaine is used as a local anesthetic. It basically is blocking sodium from moving in and creating a positive charge. Everything in the body basically comes down to these electrolytes. If I retain water, I retain sodium. If I retain sodium, I retain potassium. If I retain those three drugs, I become hypertensive. Heart rate has to go up to pump against all the fluid. The heart rate gets so high, it becomes irritated. They're at risk for VFib, VTAC, or torsades. Eventually, the sodium potassium is so fat, it won't move. So I got to kick it in its butt and make it move by giving it calcium chloride. Before I get to that point, I need to start eliminating the potassium as soon as possible, which is why I give them albuterol. So it depends on what the question's asking you. you have a tall peak T wave, 52-year-old male missed dialysis. If he missed dialysis, he's metabolic acidosis because he hasn't taken out the trash, correct? So I have tall peak T waves, rates 112. That's not too fast, it's not above 150, and it's not below 50, correct? So he's a little tachycardic, but he's not like too fast or too slow, we gotta treat him. So I see missed dialysis, tall peak T waves, rates 112, he's breathing 26 times a minute, blood pressure's 180. His blood pressure's 180 because he's retained a lot of what? A lot of fluids. He has tall peak T waves because he's hyperkalemic. He's breathing fast trying to eliminate the what? Acid. What drug will best help him eliminate that acid? Albuterol. He's breathing to try and eliminate it. Let's supplement it by opening his lungs. Let him have more surface area to eliminate the acid. Plus albuterol is going to help move the potassium back into the cell where it belongs. Albuterol would be the best choice. Bicarb would be secondary. The problem with bicarb, you give bicarb, as soon as it hits the acid, it's done. It's deactivated. So basically, you would just have to keep shoving bicarb in him to get a prolonged effect. Versus albuterol, it's going to keep the lungs open 10, 15 minutes, which is going to allow them 10 to 15 minutes of eliminating trash. Does that kind of make sense? Because as soon as bicarb equals the acid, it's going to convert and be done. And when you watch bicarb being given, there's a couple of videos on YouTube that have a person in DKA. And the person in DKA, they have a capno and they are Kussmaul's, and it's like 70. I mean, they're like massive DKA. They're unresponsive, and they show them laying on the cot, and they're just bouncing that chest trying to blow it out. They give them bicarb, and it does this for about 20 seconds, and then it's bam. Just like that. Basically what happened was bicarb entered the body. It can only handle so much acid, converted what little bit it could, and then it's gone from the system. And so you see him go Kussmaul's, about 5 to 10 seconds of relax, right back into Kussmaul's. They give him the albuterol, and you see this happen. When they gave him the albuterol, basically you see, and the number was like 40, they basically do this. What have they basically done? They freed up and eliminated that acid to where now they're not having to have Kussmaul's because they have so much surface area, they're able to regulate their acid. And then when the albuterol wore off, they went back into the Kussmaul's. So albuterol can be used for metabolic acidosis. That guy was not extremely tachycardic or bradycardic, so he got albuterol and bicarb. If I said you have a tall peak T wave, rate is 30, and he missed dialysis, what drug does he need? Calcium chloride. He's not going to respond to atropine because it's not a vagus nerve issue. It's a sodium-potassium toxicity issue. He needs calcium chloride. He may not even respond to pacing. If I give you a V-TAC or torsades and he missed dialysis, he needs MAG. Once again, we have one renal patient, depending on what phase of renal failure they're at, and depending on how we word the question, we may be given albuterol and bicarb, we may be given calcium chloride, or we may be given MAG. Rates good, QRS and T waves not, albuterol and bicarb. Rates slow, or PEA or Sicily, calcium chloride. Rates fast and torsades, MAG. They're all renal failure patients, all right? But we got to put that puzzle together, all right? So if we look at it real quick, when we take our electrolytes, we have to transpose those to our algorithms. Our algorithms are basically too fast, too slow, dead, and then we have narrow and wide QRS. If it's narrow, it makes a tall, skinny A, and it came from the atrium. If it's wide, it makes a wide V, and it came from the ventricles. So the first thing we want to look at is our strip is what's the rate, and then we want to figure out is it wide or narrow. If it's narrow, it has a tall skinny QRS. Remember, narrow is less than 0.12 milliseconds or 3 small boxes. Wide is greater than 0.12 or greater than 3 small boxes. That's wide. Give me a rhythm that has a narrow QRS.
Is the normal sinus?
KSVT, normal sinus rhythm, sinus tach, sinus Brady, what else? AFib, A flutter? What else? What about junctionals?
Yeah, well, depending on where in the
It doesn't matter, the QRS is narrow.
Yeah.
Regardless of if the P wave's inverted or absent, the QRS is narrow. If it was wide, it wouldn't be junctional.
Anything behind it, yeah.
Do what?
Everything's not beat good and beat that.
Okay? Pretty much. Pretty much. Sinus rhythm, sinus tach, PACs, PJCs, first degree blocks, second degree blocks. Third degree could be either, depends on where it's at.
Yeah.
But pretty much everything is narrow except for PVCs, bundle branch blocks, VFib, VTAC, torsades, and then I'm going to put a third degree in the middle because it could be either.
was it third degree second or the two
First degree and second degree blocks are narrow
yeah. Well,
because they're still coming from above the junction. So when we actually look at this, we're going to eliminate everything that's not too fast or too slow. It's basically what we're going to do. Too fast, we're looking at above 150. Too slow, we're looking at below 50. SVT is too what? Normal sinus rhythm, we don't care because it's between 50 and 150. Sinus tach should be below 150. I don't care. Sinus Brady we'll look at. AFib and A flutter, I don't care about unless it's too, and if it's too fast, it gets worked as SVT. Junctional, I only care about if it's too slow. PACs and PJCs are caused by caffeine and energy drinks. I don't care about them. You're going to have a headache. I don't give a shit. So basically, out of all this, what we're left with is narrow tachycardia and bradycardia. If it ain't fast and it ain't slow, I'm going to treat why you call 911. That's basically what we just eliminated. Over here, I don't care about PVCs. Number one cause of PVC is hypoxia. A bundle branch block is a conduction delay. I don't know if it's new or old. It's going to depend if it's too fast or too slow. If a bundle branch block is too fast, it's going to look like VTAC. If it's too slow, it's going to look like a third degree block. But if it's between 60 and 150, 50 and I don't give a shit. VFib is dead. VTAC, if it has a pulse, it's too fast. If it's dead, I work it like VFib. So out of all that crap, I basically got SVT and VTAC, and then I got dead. If they ain't SVT, they ain't bradycardic, they're not VTAC, and they're not dead, I don't give a shit. I am going to treat why you called 911. You have sinus tach, nausea, vomiting, diarrhea. That's great. Let's give you some fluids for your dehydration. You have AFib at a rate of 80 and shortness of breath and emphysema. Great. I'll treat your emphysema. You have A flutter at 110 with RELS, pink frothy sputum, and high blood pressure. Great. I'll treat your CHF. You see how that works? I'm going to treat why they called. I'm not going to use an ACLS algorithm unless it's narrow and fast, wide and fast, slow, or they're dead. Everything else gets treated why they called. So basically what we're left with then is we are left with SVT, VTAC, bradycardia, and dead. If they ain't one of those, treat why they called 911. Now, I have two basic options to go down. Remember, I have stable and unstable. Stable means I can try what first? Well, an SVT, yes, but I can try a drug first. Alright, so stable I can try a med first, or vagal maneuvers if it's SVT. If they're unstable, they need electricity first. Alright? Now, what makes somebody stable? And what we mean by stable, it's not that they're not sick. It means I got a few minutes to do things before I go shocking them. Alright? So, if I got a few minutes, their brain's perfusing. If their brain's perfusing, they shouldn't be altered, correct? So, if I got a few minutes, they should have normal LOC. In order to have normal LOC, you should have a blood pressure above 90. And if we have a normal LOC and we're moving oxygen and glucose, aka blood, I should have no to mild chest pain, and I should have no to mild shortness of breath. So basically, you run on this individual, heart is a narrow tachycardic rhythm at 180. The registry may not use the word SVT. They may not say that. They may say you have a narrow tachycardic rhythm at 180. SVT is a narrow tachycardic rhythm at what? 180. What if they said you have a 56-year-old male with a QRS of 0.10 and a rate of 190? That's SVT. What's the rules of SVT? Rates above 160 and the QRS is less than 0.12. What did I just give you? But I didn't use the word SVT. You are not going to walk in on a patient and they go, by the way, I'm unstable SVT.
Be nice if they did.
You're going to have to look at their strip, you're going to have to look at the rate, and you're going to have to look at the width. That's why sometimes they'll just throw a word problem out there. You have a narrow tachycardic rhythm with a QRS of 0.08 and a rate of 190. That's SVT. Now we got to determine on the stable or unstable. So 56-year-old male, narrow tachycardic rhythm at 190, states that he's feeling like his heart is racing and it has palpitations. Blood pressure is 106/60. Heart rates as you see it on the monitor. Respirations are 22. You ask him if he has pains, and he goes, I just feel weird. Do you hurt? I just feel funny. Is that severe chest pain?
No.
Is he altered?
No.
Is his pressure below 90?
No.
So we got time. Yeah. Now, if I said he's unresponsive or severe chest pain, cool pale diaphoretic, in and out of consciousness, and they will give you at least 2 of those, if not all of them, then he would be unstable and I'd go straight to electricity. It takes 1, but they're going to give you multiple. They're going to give you multiple. All right? So the opposite of this would be unstable. Decreased LOC, blood pressure less than 90, severe chest pain, severe shortness of breath. That would be unstable. They would give you at least 2 of those, if not all of them. Okay? They will give you at least 2, if not all of them. So let's go through our algorithms quick. If it's SVT, we know a couple of things can look like SVT. AFib, A-flutter, and sinus tach can look like SVT. So how do I know if it's sinus tach versus SVT? History. History. Here's an example. I've been doing this workout called Terrible Tens here lately. I get my heart rate 180 to 190. Am I SVT or am I sinus tach? Sinus tach because I'm working out and I'm creating a bunch of acid. If I'm sitting on the couch chilling and my heart rate hits 190, something's wrong, that's probably SVT. So history is going to let you tell the difference between SVT and sinus tach. Does that kind of make sense? You have a person who's been doing meth all night and the heart rate's 220. That's not SVT, that's sinus tach and meth. How do I treat that guy with cocaine, meth, PCP, LSD, as tachycardic? Calm their ass down. They went up, bring them down. Sedate them. Value reverse it. All right? That's why a lot of times they'll put an opiate with them. To keep their heart from exploding, they'll take the upper, cut it with an opiate to bring them back down. That's where you get your little speedball. All right? So we got to bring them down. AFib or A-flutter, the problem with AFib and A-flutter is when it gets RVR, rapid ventricular response, if we were to see it on the screen, it looks like this. All right? You really can't see the P waves or the flutter. And at first glance, that's narrow and super fast, correct? That looks like SVT, but when you actually march it out, it's actually irregular. So how do we determine that? Let's get a 12 lead on our SVTs. The reason why we get a 12 lead on our SVTs if they're stable, because that way we can try to determine, is it AFib with RVR, is it A-flutter with RVR, or is it SVT? Because when you get any one of those rates above 180, they look almost identical to the naked eye. I do a 12 lead and it says AFib or A-flutter, I skip to my Cardizem, calcium channel blocker. If it confirms SVT, then I'll go through my vagal maneuvers and my adenosine. Does that kind of make sense? But that's why they want you to try and get a 12 lead on the narrow tachycardic to see if it's actually AFib or A-flutter with RVR versus actual SVT. So we do a 12 lead, we confirm that it's SVT, we do vagal maneuvers, have them try and blow the syringe out, set them up, have them try and blow into this and move the plunger, and then drop them flat on their head on the cot, not on the ground, and lift their feet up. It's going to vagal them out and stimulate that vagus nerve. You could also do a carotid sinus massage as long as they don't have a history of cholesterol and plaque, because it could break a piece of that plaque loose. You can also have them grab the cot and bear down like they're trying to have a bowel movement. Hit print prior to where it slows it down, and you can see if they break it or actually see if it's AFib or A-flutter when they vagal them down. If it stays SVT, then we'll move to adenosine, 6, 12, and 12. If that doesn't work, we'll cardiovert at 50 to 100 joules or equivalent biphasic. If that doesn't work, then we'll give our calcium channel blocker. Most commonly, that's going to be Cardizem. The textbook says Cardizem's 0.25 to 0.35 mg per kg. The shortcut is small people get 15, large people get 25. That's the shortcut. A small person is a small person's about 50 to 75 kilos. 50 times 0.25. That's going to get me close to the 15 range. A person that weighs 100 kilos is kind of large. 0.25 times 100 is 25. So 15 for small, 25 for adults. That gets you in the ballpark.
So you would, are you giving electricity before the meds, or you just, it's the meds first and then?
Yeah, I went 12 lead vagal, adenosine, electricity, calcium channel blocker.
You wouldn't do adenosine and channel blocker and last procedure?
No, because if I go 6, 12, and 12 of adenosine, think of how long that's taking me.
Yeah.
I pull up, Ham here is an SVT. I do a 12 lead. I vagal him. I start an IV. I give him 6 of adenosine. I wait another minute or two. I give him another 12 of adenosine. Wait a minute or two. I give him another 12 of adenosine. I've probably been on scene 10 or 12 minutes now, and I had a 5 to 7 minute response time. And he called 911 because he was in it. I'm 20 minutes into this dude. Let's lie his ass up. Now, if I discovered through 12 leader vagal he was actually AFib or A-flutter, I would skip to the Cardizem because it's going to work better on the AFib or A-flutter than the adenosine will. So, 12 lead, make sure it's SVT. If we determine it's AFib or A-flutter, skip to Cardizem. If it's SVT, try vagal in it. 6, 12, and 12 of adenosine doesn't work. Cardiovert doesn't work. Calcium channel blocker. Cardizem is the most common. 15 to 25 milligrams. 15 for small, 25 for big. If he was unstable, pressure's low, altered LOC, severe chest pain. I'm gonna cardiovert at 50 to 100 joules. If that doesn't work, I'm gonna throw a 12 lead on and make sure I'm not dealing with AFib or A-flutter. If it's SVT, while we're trying to get our meds drawn up, we'll try vagal, adenosine 6, 12, and 12, followed by a calcium channel blocker. So all I did was basically put electricity where? At the top. Here's what you will see on the registry. Static next week, they're going to give you a card with the scenario, and they're going to give you basically vital signs and something about the patient. If they tell you, or they give you a scenario and it's unstable SVT, just rattle this off. If it's stable SVT, rattle this off, because the goal on static is they want to see if you know every part of the algorithm as if nothing worked. Vagal didn't work, so I tried adenosine, didn't work, so I tried electricity, didn't work, so I tried cardizem, didn't work. All right, you're done. That's what the static is designed to do. It's basically make sure you know how to go start to finish. A computer test, on the other hand, what it's typically going to do is it's going to give you a word problem that basically says you have a 52-year-old male, altered level of consciousness, blood pressure 70/40, and you have a new narrow QRS at 190. He is refractory to adenosine and cardioversion. What should you try next? And it will list like cardizem, Versed, atropine, and amiodarone. It's the only one that's part of the algorithm. And so what they'll do is they'll give you a couple of things that have been done, and they'll use the word refractory. Refractory means this stuff didn't work. What's next in your algorithm? And so just go down your algorithm until you find something that's listed. And a lot of people are like, well, that's dumb. Why did they do that? Here's why. Everybody in here has done anywhere from 8 to 13 ride-outs, if not more. I promise you, you were not first on scene on every call on the ambulance. Sometimes you were first on scene. Sometimes you ran by yourself. Sometimes you walked in and the engine crew was standing there and already had a lot of stuff done. Sometimes you walked in and the engine crew's doing this. You're like, what you got? I don't know, you're on the box. So you had to run a call from start to finish. You had to run a call with people in there but no help. And you had to run a call where you walked in and a lot of stuff was already done. And you have to be able to pick up wherever you happen to be on that particular call. That's why they drop you off in the middle of algorithms on the registry, because that's reality. They're not here today, but the new hybrid class has started and it has some of our Irving guys in. And we were talking about this exact same thing, and probably a month or two ago, I don't know, we ran a call. I'm riding seat on engine 12, and they dispatched us to assist medic 10 and engine 10 code 3. I'm like, all right, whatever. We get there, and the guy's in cardiac arrest. Kind of a decent sized fellow. They need help carrying him down the stairs. Two of the medics on the ambulance, they're old guys, been around a long time. They're like, hey, how many times can we shock? I go, what? How many times can we shock? He says, as many as you want. How many times you shock me? Oh, 5 or 6. Okay. They're like, hey, we gave epi. I go, okay. Have you given anything else? No. So they shocked him 6 times, and they gave an epi. I said, well, how about we give some amiodarone? And he goes, Amy who? I go, amiodarone. He goes, we carry that? I looked at my guys and go, I'm riding with him. Pick me up at the hospital. I got dropped off in the middle of their algorithm. Nice guys. They're just waiting for that drop check, and they're gone. Their combined age is 119. They don't give a shit. Because they were like, Amy who? I was like, we've only carried that drug since 99, but whatever. So that's my point, is you're going to have to walk in sometimes and pick up where they're at in that equation. That's why that test is written that way. A lot of people, well, that's bullshit. I shouldn't have to do that. That's reality. Reality is you're gonna run with the good engine crew, and you're gonna walk in and they're gonna be like, hey, we had a 3rd-degree block, we gave atropine, we paced, nothing's working. And you're like, sweet, let's try this. Or you're gonna walk in and they're gonna be like, engine driver's out in the engine, because he don't gotta get out, he's driving the engine, but he's the only paramedic on the equipment. The captain's in there up against the corners, and that rookie EMT that doesn't know anything is trying to figure out how the monitor goes on. Trying to take a blood pressure. He's not breathing, doesn't have pulse, but I gotta hit the button. So that's why the questions are written that way. So when they use the word refractory, they're dropping you off in the middle of that algorithm. Does that kind of make sense? Just go down the checklist. If it says it's refractory to adenosine and cardioversion, okay, does the calcium channel blocker listed? If it says you've tried vagal maneuvers, what's next? Well, if he's stable, what's next after vagal maneuvers is what? Adenosine. If it says he's unstable and you have cardioverted, what is your next drug? Unstable, cardioverted, what drug should I give? Adenosine, because I haven't given it yet. If it said he was refractory to adenosine, then we would go to the cardizem. And that's why we have to read that last sentence. First sentence, why you there. Last sentence, what they want and what they've done. All right?
Will you see any change when you give adenosine with fib and flutter?
A lot of times you'll see it slow down. So the question was, if we give adenosine, will we see it change? What would happen, like on this right here with AFib with RVR? You may see it do this. So you may see it do this. And then basically, and you're like, okay, that's pretty irregular. And then it goes back in where it speeds up. So you'll see that fib in the middle where your QRSs are irregular. And when it slows it down, you may see that in the middle of it after 6. And then it'll go back into it. And that's when you go, wait a second. I slowed him down. Uh-oh, it's actually a fib. Let's drop to the cardizem.
Is that the same thing with the shocking them on the unstable side? Like, it could fix it, but
could fix it, may slow it down, and that's kind of what we're doing with vagal maneuvers too. Is we're trying vagal maneuvers to see if it fixes it. If nothing else, maybe it will slow it down enough to where we can actually see: are we dealing with SVT? Are we dealing with AFib? Or dealing with A-flutter? If it doesn't break it, and that's what that first round of adenosine does as well.
Yeah.
ACLS says 6 of adenosine. Our BioTel protocol says, screw the 6. We're not doing it to slow it down. We're giving 12 to try and break it. That's why our protocol is a little different.
Dallas says if it's AFib, don't do shit.
Kind of.
Let me ask you this: on the A flutter, if you're thinking it's SVT, and you vagal them down, and you realize it's A flutter, but it's like a 2-to-1 or a 3-to-1.
Okay.
Would you be wrong with giving them cardizem and shocking them? Or
You would not be wrong. They need cardizem, and they're probably going to need cardioverted. The problem we have is we don't have that option in the BioTel system. Yeah. We had that option until about 5 or 6 years ago. Michael's correct in that 99% of our AFib and A-flutter patients, their rate's going to be below 120, and we're just going to treat why they call 911. So very seldom are we going to have to do anything for it. I told the group this yesterday. The one time I really missed cardizem, we had a lady, she was up here from Louisiana on 4th of July over in 2's district. She had an internal defibrillator. Internal defibrillators are set on rate. They're not necessarily set on, is it wide or narrow? A lot of times they're set on rate. So she had an internal defibrillator, and it was set at like 140 or 150. I couldn't figure out exactly where, because anytime she got in that range, it was popping her. So she would sit there, and her rate would get up, and she would, ow, and you would see her just flinch, and it was shocking her. She was AFib, and as soon as her rate would hit that 140 to 150, it would bust her off, and maybe for a minute it would fix it, and then it would climb again. Adenosine's not going to touch it. She needs what? Cardizem. She's getting electricity internally. We don't carry cardizem. So all we could do with her is transport her and try and make her comfortable by taking her to the hospital and giving her some Valium Reverse. BioTel didn't really want to let me give her Versed. I'm like, dude, it has shocked her 13 times since we've gotten here and put her in the back of the ambulance. And they're like, well, and I was like, okay, fine, she's seasoned. They're like, what? I was like, and I was like, what if she sees? And they're like, just go ahead and give it. Because I was like, fuck that. She's seasoned. I'll make her seize. Because that's all we have. Because ultimately she needed Cardizem to break that AFib and A-flutter, and we didn't carry it. Very seldom do we actually get to that point, but it is an option. 99% of the time of your career, the AFib or A-flutter is going to be related to emphysema or CHF, or it's just what they've been in for 30 years. And we're going to manage why they call. It's when that AFib, A-flutter gets at 140, 160, 180, 190 that we need something to work. The flip side is for the most part, we have a relatively short transport time to a close hospital to where by the time it was actually to kick in, we'd be arriving at the hospital. So that's kind of the flip side of that.
So I saw a question the other day on the unstable side. They had like 6 respirations a minute, and they were awake, not unresponsive.
Okay?
But I think I remember the answer being skipped to cardiovert and don't
Correct.
sedate.
Because they're what?
They're depressed.
And so stop and think about this. I don't want to delay cardioversion for sedation.
Yeah.
And what does sedation do to your respirations?
Depressed.
And if you're already breathing 6 times a minute and I give you Valium or Versed, your ass is buying a tube. So I wouldn't want to sedate them. I want to go straight to cardioversion. And if they're super sick, you can typically get by with 1 cardioversion without sedation. The first time next time they hear that monitor going, beep, you ain't coming near them. So if you need to, you can cardiovert them without sedation if they're extremely sick. All right? All right, let's take about 10 minutes. I want to try and get as much cardiac done before lunch. We'll go to lunch